Very good morning, dear all. Today we will have a lecture on the bone grafts. We'll go through the classification of bone grafts, the biological mechanism of bone graft, and what are the various types of bone grafts available. So, what is a bone graft? It's a material used to facilitate bone formation. So there is some biological mechanisms that support the use of graft materials. That is whether the graft material is having osteogenesis property, it's having osteoinduction, or whether the bone graft is just having a osteoconduction property. First is osteogenesis. So when you say a bone graft is having osteogenesis properties, when the bone graft material has vital or living osteoblasts. So if a bone graft is having living osteoblasts, then it will have the property of osteogenesis. So the second biological property is osteoinduction. Here, unlike the bone graft which are having osteogenesis, where vital osteoblasts are present, these bone grafts will have growth factors, BMPs. So when these bone grafts are placed, these growth factors will stimulate the progenitor cells to differentiate into osteoblasts, and then they will form the bone. Osteoconduction. So these bone grafts are just filling materials, space preserving materials. They just allow the ingrowth of capillaries and perivascular tissues and osteoprogenitor cells into them to form the new bone. But as such, they don't have any vital osteoblast like bone graft which has osteogenesis property, or either they don't have any growth factors such as graft which are having osteoinduction property. They are just synthetic materials which are used to preserve the space and help in formation of new bone. So we classify bone graft as bone derived and non-bone derived. Bone derived can be autogenous graft, allograft, or xenograft. Non-bone derived will be synthetic bone, that is the alloplast. What is autograft? So when we transplant the bone graft from one site to other site within the same individual, that is known as autograft. So for example, when we are regenerating periodontal defect, if we take the bone graft from any part of the mandible, maxilla and put it into the defect, that becomes the autograft. It might be an intraoral or extraoral. So if we take iliac crust and within the same individual, iliac crust graft and put it into the defect, again it becomes a autograft. So what is a allograft? Where the bone graft is transplanted between individuals of same species. Say for example, dead person, we extract the bone and we refine it and we preserve it and we can use it for bone regeneration. So the graft is between same species. That's a human species. That becomes a allograft. So what are xenografts? So graft obtained from different species, that is of animal origin. Say for example a cattle bone. And the last is alloplast, which is synthetically derived material, and they don't come from any human or animal origin. So some of the ideal requirements of bone graft would be it should be biologically acceptable, no doubt. It should give us a predictable results, and it should be clinically feasible. So enough material to require the graft material. So if it's autograft, it should be easily procurable. If it's allograft, we should get in sufficient quantities, and it should also give. It should minimize post-operative hazards such as sequestration, resorption, and all. And patient acceptance is also kind of very important because some of the graft materials are from animal origin. So when you are using such graft, it's always better to tell the patient what form of graft material you are using. Let's begin with autograft. These are the gold standard in bone regenerative grafting materials. It's only graft which has all the three biological functions of osteogenesis, induction, and conduction. And no doubt this graft gives the most predictable results when compared to any other type of grafting materials. So the autograft we can procure it from both the intraoral side as well as the extraoral sides. See one by one. Bone from intraoral sites. So what are the sources of bone intraoral sites? We have within extraction wounds, very good source of autograft, cancellous type of bone regenerative materials. We can have bone from edentulous ridges, or we can simply use a trophine to get autograft within the jaws without damaging the root. Or sometimes when we are doing osteoplasty, aerostectomy, whatever bone we get, we can utilize the same bone for regeneration in other areas of the defect. Some of the equipments available aside to procure the graft materials. We have something called as bone trap that I'm going to tell you later. We have a trophine burr, and we have bone shaving devices, and of course a simple suction trap which filters out the small bits of bone fragments which uh, can go waste during sectioning process. We have intraorally, we have both cortical and elasticus bone. We'll see what are the good size to get intraoral cortical bones. So the source of cortical graft material can be the lingual ridge of mandible, any exostosis. Again, the edentulous ridge, bone distal to the terminal tooth. Again, bone removed during osteoplasty or osteectomy, or any part of the maxilla and mandible at least 5 mm away from the root surface. Cortical bone chips. So what we do is we use a bone shaving device and we scrape out the bone during our osteoplasty and osteotomy procedures. The only problem is the bone particles are larger in size and it has a potential for sequestration. So there is something called as osseous coagulum. This is nothing but a mixture of your bone dust and the blood. And of course, it's a smaller particles of cortical bone. We saw in the previous slides, smaller particles mixed with blood that forms osseous coagulum. What is bone blend? So we just saw the osseous coagulum. Okay, so what we do is we take this and put it in this small device, the plastic capsule. The pestle is there. So this is similar to the trituration device of amalgam. If you remember, we have a small capsule, right? We put it into the trituration device, amalgamator. So similarly, put the bone dust and the blood in this capsule, triturate it, we get a workable mass which we can use to pack the bone defects. Let's see intraoral cancellous bone marrow, which are the good size to get a cancellous bone intraorally, tuberosity and healing sockets are the excellent source of intraoral cancellous bone. Of course, we also can try to get it from the edentulous ridges as well. Maxillary tuberosity, we can procure good amount of cancellous bone. So all we need is a ronger. So open up a flap over there, take the ronger, and you can crush the tuberosity area to get sufficient amount of cortical bone, sorry, cancellous bone. So as mentioned earlier, we can get a good amount of cancellous bone from healing sockets. So once you've done the extraction, just leave it for 1 or 2 months and take your curate, scope out the apical portion. We get a good amount of cortical bone that you can use to pack the defects. So there is something called as bone swaging. We use it to treat any defects which are there on the distal aspect of the last remaining tooth. So it's technically a difficult thing to do it clinically because we need to see few things. One is there should be a sufficient bone distal to the defect, and we should fracture the piece of bone distal to it without fracturing the base, and slowly we should push this bone to fill up the defect. So we are still discussing autografts. So we just discussed autograft from intraoral source, and we discussed which are the sites which are good for cortical bone, and which are the sites which are good for cancellous bone. Now we can get the same autograft from extraoral sites as well. So one such site is iliac crest. So when you require a large amount of graft, you can procure from iliac crest, as it provides a good amount of cortical as well as cancellous bone. But this procedure requires hospital admission, and it has to be done under general anesthesia, spinal anesthesia. So recently, this particular graft from iliac crest is no longer used for perio defects. They noted some difficulties right from procuring the grafting material, and they noticed that when we use such graft, there is a lot of resorption, infection, and varying degree of healing, and rapid recurrence of the defect. So currently, uh, we don't take much graft from iliac crest for periodontal defects. So sometimes we can take graft from tibia when lot of cancellous bones is required, and again there is a second surgery is required and requires hospitalization, and post-operative complication follows. So again, this is indicated only in selected few cases. So let's move on to allograft. So these are the graft transplanted between the same species. So in human, from one human being to another human being. Mostly we take the bone from the dead person, process it, store it in vials, and use it to fill for period defects. So let's see how it is done. So this is the way the allografts are obtained and prepared. So they are obtained from the cortical bone within 12 hours of the death of the donor. So they are cut into pieces, washed in absolute alcohol, defatted and defrozen, and they are exposed to a lot of radiation, freezing, and chemical treatment. And all these things are done to suppress the antigenic potential of the graft. So once all the antigenic potential is reduced, they are remineralized, they are grounded to the various sizes, and they are freeze dried, and finally they are sealed in a vacuum containers. So now let's see the various types of allografts. We have frozen, iliac, cancellous, bone and marrow. Second one is freeze dried bone allograft. Third one is demineralized freeze dried bone allograft, DFDBA, and we have irradiated cancellous bone grafts. First type of allograft is a frozen iliac cancellous bone and marrow. So the use of this particular graft is less in perio because of disease transfer, antigenic potential, and the need of extensive cross matching. Next type of allograft is FDBS, freeze dried bone allograft. We commonly use it. So these grafts are dried at very low temperature, a process called as lyophilization. So there is no liquid phase in the whole process. And the same FDBS, when the mineral content is removed, it becomes demineralized freeze-dried bone allograft. So once the mineral contents are removed, what happens is it exposes all the collagen and the growth factors, the BMPs, the bone morphogenic proteins, which are embedded in it. So this is the feature which it's present in this particular graph, that is the osteoinductive property. So what happens when you put these graft materials into the pocket area or the defect area, bone defect areas, these BMPs will stimulate the nearby osteoprogenitor cells. They will convert into the osteoblast and lay down the bone. So what are the disadvantages? Some of the disadvantages are risk of graft rejection, course of infections, non-union, and rapid resorption. Next, we have xenograft. These are the graft obtained from animal origin. And, it can be from a cattle bone, or a coral, or a product of alga. So we have natural hydroxyapatite and E-organified bovine bone. So regarding natural hydroxyapatite, these are synthesized from calcium carbonate skeleton of coral, and the three-dimensional microstructure is similar to that of a human bone, and these materials are highly biocompatible and they bond readily to the adjacent tissues. And the example is Interport 100. This is a commercial name, so, which is available in the market. We have deorganified bovine bone. It's a bovine origin. So, example of one such material which is available in the market is Shoegraft by Bioas. So, at the time, this was known as the most physiologic bone substitute, as it becomes completely incorporated and integrated with the human bone after remodeling. What are the disadvantages of deorganified bovine bone? Besides its an animal origin, there is an increased risk of human response, host immune response. It's quite brittle, so it's always recommended to be used with a membrane. So we'll go to the last part, that's alloplast. There are three main group of alloplast. First is the ceramic, the calcium carbonate, and the composite polymers. Under ceramic, we have synthetic hydroxyapatite, tricalcium phosphate, and bioactive glass. And we'll see one by one. So under ceramic, we have synthetic hydroxyapatite. We have seen natural hydroxyapatite in the xenografts. So synthetic hydroxyapatite, they are quite biocompatible and bonds readily to the adjacent organs of tissues. And the calcium to phosphate ratio is in 10 to 16. And some of the trade names are osteogen and osteografts. So next we have tricalcium phosphate. Its chemical structure is similar to hydroxyapatite, and the calcium to phosphate ratio is around 3 to 2. So depending upon the manufacturing sintering temperature, there are two types of tricalcium phosphate, alpha and beta. So the alpha, the sintering temperature is 1080 degree, and this resolves very slowly, so rarely used. And the beta tricalcium phosphate is available where the resorption is around 8 to 12 months. So both these are available in the market. The alpha calcium phosphate are available in the trade name Biovision, and the beta is available under trade name of one Xenografts or Osseous. Next we have is a bioactive glass. So it's a mixture of again calcium salts and phosphate in the same proportion as human bone in teeth. And this particular graft has an excellent handling capacity, and it readily bonds with the bone to form hydroxycarbonate apatite layer. So we commonly use in for perio procedures. It's available under the trade name Perioglass, Bioglass, or Biograde. So the last bone graft to discuss is composite polymers and allograft. So we have both resorbable and non-resorbable. Non-resorbable we rarely use it. So it's composed of polylactic and polyglycolic acid. So high molecular weight compound, they don't usually break up and they remain in the site of placement for more than 3 years. And the low density copolymers will break down around 3 to 4 months time. Start breaking down in 3 to 4 months time. They are available in the form of powder, sponges, or gel. And one such example is Physiograft. So we do have non-resorbable composite polymer bone grafts, which is made up of mixture of polymethyl methacrylate and polyhydroxymethyl methacrylate. We rarely use such materials. So hope we have a good idea about, got a good idea regarding many types of bone grafts available for our procedures, and which is the best bone graft to decide. Nothing can beat autogenous bone graft, which is the gold standard. The second best would be allograft, which has some growth factors such as BMPs. And we have plenty and plenty of alloplastic materials. So sometimes if we need adequate grafting material, so what we can do is we can mix the autogenous graft with sufficient allograft or alloplastic materials also. Thank you.